I think we need leaders who have humility to recognise that they don't have all of the answers, and I think we as a community have to demonstrate to our leaders that we don't expect one person to solve all of this. So my message today is very much that we are all collectively leaders in our own communities. We are leaders in the AOMT community, we're leaders in the international musculoskeletal community, we're leaders in our own clinical practice communities, in our research communities, wherever we're working.
Clare Ardern, welcome to the show.
Thanks, Jimmy.
You are going to be on the big stage very, very shortly.
Yes.
Your keynote, Right Care, Right Place, Right Time, Musculoskeletal Rehabilitation Clinicians Leading Equitable and Sustainable Healthcare. Looking into care, musculoskeletal care is how it's delivered, highlighting digital triage, advanced practice physiotherapy, and global models that expand access to quality care. You're covering a lot.
Ambition is
like
my
all in
middle
one
name.
talk.
Yes.
That could be an entire half a day.
It could. It absolutely could. And that was my goal, was to start conversations and get people thinking about what they're seeing showing up in their practice and where musculoskeletal health might go into the future.
All right, when we're talking about future, and you mentioned the word digital, if you've been, living under a rock, there's these things called AI, and there's ability to see and hear and feel and touch from far distances using these technologies. You lead the DigiMSK team at UBC. When you talk about right care, right place, right time, what does it actually look like in a digital model?
It's looking like, how do we use technology in a way that helps people find access to the care that's going to help them at the time they need it? So we focus a lot on the emergency department, and the analyses, the work we've done looking at who's presenting to the emergency department and why, what are they seeking care for. We've identified that a lot of people end up at the emergency department with musculoskeletal conditions. A lot of it is back pain, which is not surprising when you consider that back pain is so common. Right. Yeah. So a lot of people are ending up in Emerge, and it's not really a great place for most people to get care because the physicians are not well trained in how to best manage musculoskeletal conditions. They are often dealing with people who are way sicker. So if you show up with your back pain, you might end up sitting and waiting for a very long time, even though you're in really severe pain. So it's not to diminish the pain people are feeling. It's about recognizing that there are ways we can help people find care that's going to suit their needs. And there's also providers who are probably better trained to deal with the musculoskeletal conditions and the problems people are presenting with.
When you go to engage people who are in emergency departments, my friend and colleague Rebecca Griffith is hammering on that and trying to teach people how to do that. What do you have to overcome? Is there like a preconceived notion of I'm sure years ago, I remember when I was in PT school, was in the emergency department. That doesn't make any sense until you hear about why it makes sense, and then all of a sudden the light bulb turns on and it makes perfect sense. What do you have to overcome to get people to understand or at least be open to hearing that?
From the clinician's perspective?
Yeah. I guess both. That's a good point. Yeah, both.
So I think there's two aspects to this. One is, why are people going to the emergency department? So why are patients presenting? And a lot of it is because they don't have a family physician or a nurse practitioner that they can see. It's too expensive to go to private PT care. They think it's really urgent, and my pain is so bad, and I've been taught, society teaches me that when I have really severe pain, this is an emergency. Yeah. So I'm really conscious that I'm not blaming patients for coming to the emergency department, but what I think we can do is have a clinician in the emergency department who can recognise what's going on and help them find care that's not immediately going for imaging, not ending up with an opioid prescription, ending up hopefully with some outpatient PT care to help manage their back pain in a way that's more sustainable. And then I think to bring clinicians into that setting, the conversations we're having with the Emerge physicians and with other clinicians who are working in the emergency department is that they're crying out for help. They're overworked. They want to help all of the patients who come through the door, and they just physically can't because it's so busy in the emergency department. So in my experience, we've had really positive conversations with other clinicians, with our medical colleagues, our nursing colleagues, saying, yes, please, we would like help. And then it's, I think, about tailoring it to the different emergency department. Different emergency departments look different because they see different patient communities, all of that. But I think there is really an appetite now for bringing musculoskeletal training into the emergency departments.
Good.
And I think the other thing is that this is not new, because quite in rural areas, quite quite often we're seeing sports physicians covering the emergency department after hours or on weekends.
Out of necessity, yeah.
That's right. So I think it's about saying who in our clinical community has the musculoskeletal skills. This is not an entry-level position either. This is, you have specific MSK training, and then, you know, to me, it's physios all the way.
Yeah. All right, well, so you've worked physically, geographically across Australia, Europe, now Canada. What have you seen internationally that could reshape access to musculoskeletal care here in the United States or anywhere in North America?
Well, that's what really got me on this path of looking at the emergency department. We've got colleagues in Australia who we collaborate with who have been working in these models for quite a long time. In Perth, in the western part of Australia, in Melbourne, putting together virtual emergency departments that are run by physios to manage low back pain. So I think there's a lot of models operating already that we can tailor to the US system, tailor to the Canadian system, and even those two systems look very different, so we're going to need different models. But I think there are some good examples that are already out there. The Australian models, and that's similar to what happens in the UK also, the data that we have studying these models would suggest that it reduces unnecessary or unwarranted, I should say, imaging referrals. It reduces opioid prescriptions, it reduces the number of people who are representing for additional emergency department care. People are ending up in the right place at the right time, getting the right care, which is where the catch line or the tagline for the presentation.
That's the goal,
from.
right? Yeah. Right, exactly. Clinicians hear digital health and think probably, when I do it anyway, I don't want to put this on anybody else. When I hear digital health, I think telehealth. There's got to be more to it than that.
Oh,
so what are we missing when we stop just there at telehealth?
There's a lot more. So it can mean a phone call. It can mean the Zoom consultation, tele-rehab, of course. We do a lot of work in virtual triage, and there's a lot of apps now where you can have an app on your phone, or you can ring a phone line and it will ask you to describe what your symptoms are and then make a recommendation about where you should go next for getting care. So there is a lot of different technologies. Even people are testing things like ChatGPT and other publicly available large language models that actually they perform in many cases better than the existing types of tools that have been purposefully designed for the health system. So I think the fact that large language models and AI is developing so quickly means that it's really flexible. And you know, there are issues, of course, ethical issues, environmental issues around AI. So I think we have to be a bit careful in these conversations. And I certainly don't want it to come across as if I'm just saying AI is the panacea, it's the solution for everything. That's
like
right.
Everything else.
That's right. And we've got to figure out, and that's what we're doing as a research team, is trying to figure out how do we make these things work for us rather than us working for the machines.
Right. I mean, you can see the application. It would be difficult for you not to see the application because things that you were using 6 months ago now have AI sort of injected them. I ride a Peloton bike, and now it's saying, it's able to analyze my last 10 rides worth of data. I had access to that data. I wasn't doing anything with it, right? I wasn't looking at what my rides were. Now it's saying, hey, let's just, by the way, and a little nudge, Jimmy, you're averaging this many more watts. Maybe we should up your whatever. And I was like, that sounds great. I probably wouldn't have done that myself, but it was able to analyze, read, react, and then suggest. And I said, absolutely, will change my courses. So I do agree, and I'm glad to hear you say it, which is figure out how to use it for us instead of us working for that.
Yeah, and many people will now work in practices where they've got AI scribes in their practice, listening in on their consults, doing their notes, transcribing their notes, and talking with colleagues who work with these tools. They find it saves them a lot of time. It's, again, not replacing you doing all of the note-taking, but it's helping you. If you use any of the Microsoft suite of products now, you've got Copilot built in. You don't have a choice. So it's really all of this stuff is being foisted on us, I think, and that worries me a bit. And I think in our research team, we're really interested in studying, is this a good idea before we just go and wholesale accept everything?
How do you approach something like the AI scribes? Like, do you start using, what do you, as a researcher, where does your brain go? Because when you look at it from a clinician who's elbow deep in patients, they're saying it's going to save me some time. I'm going to sign my name to this, so I want to make sure this note is accurate, but it's saving me some time. I heard from a friend's father who brought it to them, and he said, my PT looked at me the whole time. that was strange, right? If my doctor looks at me the whole time, that is now the strange part. But they were able to do that because they weren't leaning over and giving them a nod every couple seconds after they had written a little bit. So how do you approach, where do you look when that piece of digital scribe comes out? Where do you look to see, is this good, bad, indifferent, or...
I'm looking at the safety and security of the data. So where are the data being housed? Who owns the server? And most health systems, well, all health systems will have a lot of emphasis on privacy and security. So there will be some systems that you don't have access to because whoever's running your health network doesn't allow certain services. And you know, at the university where I am, we're given access to certain things and not to other things because of where the servers are based. So that's the first thing, is where are these data going? As a researcher, what worries me too is that these AI tools often are complete black boxes. We have no idea how they're working. We can't work out, we don't have access to the algorithm they're using. We don't know how they're training. We don't know what they've been trained on.
So black box meaning you can't see what's under the hood. You just see the output. So you're saying, okay, I see what's coming out, but how'd you get there?
Exactly.
If I don't know that, I can't validate it, or I can't measure it, or I can't look at those things.
That's right. I don't even know how biased this is, because we know that AI, like all of us, we all have biases. Yeah, that's right. So what is it missing? And if you don't know what it's been trained on, you can't make some judgment calls about where those biases are likely to sit. So they're two of the things that I'm looking at. Certainly the security and the privacy, but also what is it? How is it getting to what the output is? And certainly I agree with you that there are some huge benefits in time and in that human-to-human interaction. If you're not staring at your screen the whole time, that's a great win for healthcare.
What can you see when you're actually looking at a patient?
Yes, exactly.
Like I would love to see if there was information like what amount of eye contact is average these days, and what could something like these types of tools actually adjust. You're an editor, researcher, and clinician. All three of those things. Any one of those things is a job, but you do all three. Just piling it out.
Well, I don't practice as a clinician anymore, so I should caveat that.
All right, well, you did.
I'm trained to practice as a clinician, and I have practiced as a clinician.
How do you help therapists interpret research without getting lost in stats or paywalls? How do you help translate? That's simple. It's not easy, though.
It's not easy. I think finding out, having simple ways that you can look at a paper and go, yeah, I trust this. So some clues would be, where is it published? You know, I think we all get that in the age of social media, that there's a lot of stuff out there that you have no idea the veracity of it. So check the veracity. Is it from a reputable source? Is it from a source that you can check? Can you go back and follow the references and see where it's come from and check it? Exactly. Speaking of AI,
do they exist?
That's right. It will make up stuff. So those sorts of things are good starting points. And I also love to recommend knowledge synthesis products. So things like clinical practice guidelines, systematic reviews, those sorts of things that where the researchers have done the work. A Cochrane guideline is another example, Cochrane review, where the researchers have done the work of putting the information together, synthesizing it for you, and then it's about looking at, again, where has it come from, who's been doing the synthesizing, what's the information that's underpinning it, and instead of you going and having to chase down 30 different references to figure out what's the best way to treat hip OA, you can go to the clinical practice guideline from APTA Orthopedics and know that that's a trustworthy organisation. It's been put together in a robust process, and then you can feel a bit more confident that the output is something that's going to have meaning for your clinical
I remember
practice.
going through research. Shout out to my professor Jason Craig, who showed us that pyramid and explained the different levels of research and how much work goes into them and what that means. And in an age when you can launch a website in 10 minutes just because something's published and someone else can find it and refer to it does not make all those things equal.
No,
understanding that.
It doesn't. And I think the other thing is that I think we tend to say social media, that's untrustworthy, but there's a lot of great stuff that you can find. People talking about research, promoting new papers that they might have published, promoting podcasts, infographics. There is a lot of knowledge translating, disseminating content that goes on those social media platforms. And again, we come back to who's producing it, what's the source of the information, can you trust it, what's the incentive, what's the conflict of interest, who's getting paid to do what.
Sure.
All of those sorts of things, I think, are questions to ask when you're listening to a podcast like us talking today, or when you're looking at an infographic or something online.
It's a delivery device.
Yeah.
I mean, what we're doing right now is being recorded today. Someone's going to hear it a week, a month, a year from now. It's a delivery device. Like, this is what we did around the campfire, right? So, but you only have so many types of media, right? Audio, video, pictures, words, that. So questioning those things constantly and asking those things, it's neither good nor bad. It's how someone is using those things. So thank you for supporting communications. It's neither good nor bad, but of course, yes, it can be used for misinformation or to lose trust or to lead someone astray.
Yeah, and the hard thing is that there is so much information out there, and as a busy clinician, you're struggling just to keep up with your day-to-day clinical practice, let alone having to read the hundreds of new papers. So, there is just no way that we can physically do all of this. And then it's find those networks and those outlets that you trust.
They earn your trust.
That's right.
Yeah.
And then come back to those rather than feeling like you've got to filter through absolutely everything, because again, that's just impossible. No, you can't. And I guess too that coming back to our point about AI, it does make stuff up. It makes up citations.
Sure.
It hallucinates. So please don't just trust that something you've typed into ChatGPT or Claude is the real thing. You need to go and chase down some of those citations.
But verify.
Yes.
Someone famous said that once.
Yes, I think so.
If we gave every clinic a DigiMSK style toolkit tomorrow, what's the one metric you'd want them to track to prove impact?
I think I am really focused on equity and access for people.
Okay.
So
what's that mean?
So can it change who gets access to care and that everyone can get access to care? Because if I take our example in British Columbia in Canada, 1 in 5 people in Canada does not have access to a family physician or a nurse practitioner. They're the best estimates we have. So right there, if we're saying that you need to get a referral from your family doctor to see an MSK specialist, a physio, then we're stuck, because 1 in 5 people won't even have access. You're already losing 20%. Exactly. So what I'm really focused on is how can we use different tools, whether it's in-person clinics, whether it's digital tools, whatever it is, to help reach as many people as we possibly can. And then we have to go out and find who in the community is underserved by musculoskeletal care, and maybe that's people who are living in rural and remote areas, or Indigenous communities who do not have as many clinicians in their community, and then finding ways to reach those communities, talking with those communities, working with those communities, and finding solutions that are going to work for them rather than telling people what they need and what's going to work. That never works. So it's building those partnerships with communities.
We've tried that.
Yeah.
It feels good.
Yeah,
a lot of moving, not a lot happening.
That's right. That's right.
You're talking about leadership in musculoskeletal health. What kind of leadership do we actually need right now? Policy, research, grassroots clinical. What types do we need? We
need all of those. And I think we need leaders who have humility to recognise that they don't have all of the answers, and neither are we. I think we as a community have to demonstrate to our leaders that we don't expect one person to solve all of this. So my message today is very much that we are all collectively leaders in our own communities. We are leaders in the AOMT community, we're leaders in the international musculoskeletal community, we're leaders in our own clinical practice communities, in our research communities, wherever we're working. And each of us, no matter what level, whether we're in our first year of training as a student or whether we're in our 30th year of practicing as an AOMT fellow, we can all lead from different places, and that's really important, and that's how we as a community move forward, is having the humility to bring people into that leadership journey, help shape the path, but not telling them what they have to do.
Yeah, wow, well said. Last thing we do on an episode is called the parting shots. You're only allowed to have one. What's your one mic drop moment or soapbox statement that you want to leave with the audience? You can go over something you've already talked about, or you can completely go rogue and bring up something new.
I think my mic drop is what I was talking about before. Can we please have leaders with humility? I've seen so many of them at the conference already, so I know they're out there, and I would like for us to build pathways for those people who are not necessarily the loudest people in the room. They're often the people working in the background, supporting others. How can we open the pathways and broaden the church, if you like, to bringing more people into this leadership journey?
Clare Ardern, appreciate your time here at AOMT. Thanks for doing what you do all over the place.
Thanks, Jimmy.
Thanks for listening to Hands On, Hands Off, the official podcast of AOMT. Subscribe now so you never miss an episode, and connect with us at aomt.org or at AOMT on social. Opinions are those of the guests and not official AOMT policy. See you next time.